Bismillahirrahmanirrahim. Today we are going to start with the gastrointestinal system, and we will be beginning with the embryology of this session. So without further ado, let's get straight into it. The very first thing is about the normal gastrointestinal embryology. Foregut, esophagus to upper duodenum, starting from the esophagus all the way, even including the oral cavity, all the way to the upper duodenum. This is our GIT embryology. The midgut is from the lower duodenum to the proximal 2/3 of the transverse colon, and the hindgut is distal 1/3 of the transverse colon to the anal canal above the pectinate line. Midgut development. The midgut development the midgut development in the 6th week. So there is a very significant event that happens between 6th to 10th week. So in the 6th week of gestation, there is a physiologic midgut herniation through the umbilical ring because the GIT is growing at a very rapid pace, and there is not enough space in the fetal gut to compensate for all these GIT enfoldings to compensate for that. So that is why there is a physiological herniation of the GIT content at 6th week of gestation. Then there is a rotational activity, and at the 10th week of gestation, that GIT content that was herniated, that comes back to the abdominal cavity. At the 10th week, it returns to the abdominal cavity with rotation around a superior mesenteric artery, total to 70-degree counterclockwise rotation. So when the gut starts herniating outwards, at that time there is a 90-degree counterclockwise rotation, and when it is coming back, there is another 180-degree counterclockwise rotation. So a total of 270-degree counterclockwise rotation is seen. Then we have it over here. These are some problems. So Uworld point is that a case of newborn with bilious emesis. Cecum is found in the right upper quadrant and fixed with a fibrous band to the second part of the duodenum. So cecum is in the right upper quadrant, and that is fixed to the second part of the duodenum, as you can see in this picture over here. Like the cecum is present in the right upper quadrant just below the stomach, and these are the lad bands which are connecting the cecum to the posterior abdominal wall maybe. And here we have the duodenum, and the appendix is like that. So this is a the case is intestinal malrotation. The answer to that is intestinal malrotation, and then another picture to that. Here you can see that there is a cecum over here, and the lad bands are connecting this cecum overlying the duodenum. So these lad bands are coming above the duodenum. They are bridging over the duodenum and thus compressing the duodenum. As you can see, a very enlarged or swollen duodenum is present over here. This is a picture of volvulus. We'll see that later. So intestinal malrotation can cause two conditions. Both of them can cause intestinal obstruction and thus bilious vomiting. Number one is cecum in the right upper quadrant with adhesive bands which compress the duodenum. And number two is midgut volvulus, which is intestinal ischemia due to the twisting around the blood vessels due to twisting of intestine around the superior mesenteric artery. So both the problems are happening around the superior mesenteric artery because we know, as we have seen over here, that the herniation was, or not the herniation, the rotation of the gut was happening around the superior mesenteric artery. So if there is malrotation, so there will be a problem, like there will be lad band formation and the cecum in the right upper quadrant. And the second thing is, like when the midgut volvulus is there, so suppose this is the anterior wall of the gut, and here we have the posterior wall of the gut. So the superior mesenteric artery is coming in the posterior mesentery and supplying like that. If there is a volvulus, so the superior mesenteric artery that was coming like that will be compressed in this twisting of the bowel, and ultimately there will be ischemia. So midgut volvulus is the intestinal ischemia due to the twisting around the superior mesenteric artery that will lead to impaired perfusion, and gangrene and perforation will be there. There is an NBME point that bilious emesis in the neonate is a sign of intestinal obstruction below the second part of the duodenum. And another thing that you must remember, that the foregut is starting from the oral cavity, then it goes down to the pharynx, and then the esophagus, then stomach, and then duodenum, until the major duodenal papilla. You know that duodenum is like that. We'll see the anatomy of duodenum in detail, but there are four parts of duodenum. There is first part A, then B, C, and then D part. So A part is the horizontal part, then descending part, then the horizontal part moving to the left side. So there are the major duodenal papilla in the second part of the duodenum, and above this major papilla, this opening of the pancreatico-duodenal duct in the major papilla of the duodenum happens in the second part. Above this papilla, we have foregut, and below that we have the midgut. So this is the demarcation between foregut and midgut. I just wanted to highlight that point. Now let's move forward. Then moving forward, there is an NBME point. We did that. Now there is a differential diagnosis of the bilious emesis in the neonates. What are the conditions that can cause greenish vomiting or the bilious emesis in the neonates? Number one is the midgut volvulus. Number 2 is the adhesive bands due to the intestinal malrotation. Both of these conditions we have just seen over here, like the adhesive bands and the malrotation. The third condition is the intestinal stenosis and atresia. We'll see that in detail, but the problem is that during the embryonal development, for example, we're talking about the duodenal atresia, if I'm talking about that. So in the duodenum, the problem is that during the embryology there is repetitive effects in which there is a luminal organ forms, then the cells start proliferating inside that because of no reason, and then after some time that gets recanalized again. So in the duodenum same thing happens, that the duodenum firstly it is like a luminal organ, a hollow organ, and then cells inside the lumen starts proliferating and then obstruct the lumen completely. After that it is supposed to be recanalized, and if the recanalization does not occur, resultantly if there is no recanalization like that, so resultantly we are expecting to have an intestinal stenosis. And if the intestinal stenosis, if the obstruction in the duodenum is happening after the major duodenal papilla, after the bile has entered the duodenum, so the fetus or the child, the infant will be having the bilious emesis. The ventral wall defect. The ventral means interior, so the interior wall defects. How do you remember ventral as an interior wall? So if I write it like that and then I turn it around, so it becomes like an A. Yep, something like that, and you can do it like that. So ventral or anterior means it's one and the same thing. So the ventral wall defect, the developmental defect due to the failure of the rostral fold closure. For example, the sternal defects, ectopia cordis. If there is problem like the whole interior wall of the body, there is defect in the whole interior wall, not only of the abdominal wall. So if the problem is with the sternum, so there will be ectopia cordis. The lateral fold closure, if the problem is with them, so there will be omphalocele or gastroschisis. Both of them will be discussed in detail below. And the caudal fold closure, if there is a problem with that, there will be bladder exstrophy, and this thing will be discussed in the repro unit, inshallah. So let's talk about the gastroschisis and the omphalocele. The gastroschisis etiology, it is the extrusion of the abdominal content through the abdominal fold, typically right to the umbilicus. There is no specific association that why is it present mostly on the right side, but it is present most commonly on the right side of the umbilicus. Like suppose this is the fetus and this is umbilicus, this is the right side and the left side. So gastroschisis, that is herniation of the naked intestinal loops outside from the body to the outside environment, that is happening most commonly on the right side of the umbilicus. So coverage is not covered by the peritoneum or amnion. The abdominal contents are coming out of the letter G. Association, they are not associated with the chromosomal abnormalities. These two things are very high yield. Firstly, that it is not associated with any kind of chromosomal abnormality, number one. And number two is that suppose I write gastroschisis like that. So there is a gastroschisis. So this means that there is a opening. There is a point of defect in the letter G from here to here, right? So the intestinal content has come out of that. That is just an analogy to remember it, and pretty good analogy. So you can remember it like that. The gastroschisis is not covered by any kind of covering, neither the amnion nor the peritoneum. Secondly, the gastroschisis is not associated with any kind of chromosomal abnormality. And another thing that you must remember about the gastroschisis is that gastroschisis has a very good prognosis. Like suppose there is a small gastroschisis, so you can put those loops slowly but manually back into the body cavity, and you can stitch the defect if the gastroschisis is small. But if the gastroschisis is large enough, then you have to do surgical manipulations, and even then the prognosis is very good in comparison to the omphalocele. Now let's talk about omphalocele. Omphalocele is the failure of the lateral walls to migrate at the umbilical ring. Persistent midline herniation of the abdominal contents into the umbilical cord. Do you remember that we talked about midgut herniation in the 6th week, and then it comes back in the 10th week? If that does not happen, so there will be an omphalocele, which means a persistent midline herniation of the abdominal content into the umbilical cord. And there is a failure of the lateral walls to migrate to the umbilical ring. The problem is on the level of umbilical ring. The coverage is surrounded by the peritoneum. Light grey shiny sac will be present, and the abdominal contents are sealed in the letter O. You may say that like it is starting from the O, so the abdominal content is present like this, like it is an O, and the abdominal contents are present within the O. So that is, which means that they are covered. Associations. So gastroschisis has no associations, but the omphalocele has a lot of associations. Number one, it is associated with the congenital anomalies like trisomy 13 and 18. Then Beckwith-Wiedemann syndrome, we'll study about the Beckwith-Wiedemann syndrome when we talk about the renal cancers. It is important over there. And structural abnormalities, for example, the cardiac, genitourinary, and the neural tube defect. Now, keep one thing in mind that there is a very, very common practice among the medical students, that whenever they are supposed to make some congenital chromosomal abnormality associated with some disease, so the Down syndrome is the first association that comes to mind. Like if I'm saying that there is a problem with the child and there is some syndrome that is associated with that, and a chromosomal abnormality, so the first thing that comes to my mind is Down syndrome. But remember, Down syndrome is not associated with the omphalocele. It is not associated with omphalocele. It is that Edward syndrome, the Tau syndrome, Beckwith-Wiedemann syndrome, which may be associated but not the Down syndrome. The GIT abnormality associated with the Down syndrome is that thing that we call Hirschsprung disease. So Hirschsprung disease is associated with the chromosome number 21 abnormality, trisomy 21, that is also called as Down syndrome. So here you can see a picture of omphalocele, and there you can see gastroschisis. So in the omphalocele there is a covering, the grayish covering that is surrounding the herniated loop, and if I could zoom it in, you can see that there is a herniation of the liver as well. The liver has also been herniated, is also herniating outside into this omphalocele cavity. In this picture you can see gastroschisis. So I have to zoom this picture in and then you can see it better. So in the gastroschisis there is a child, and the diaphragm is like that. Diaphragm separates the chest cavity from the abdominal cavity. We'll see a clinical vignette or clinical linkage with this diaphragmatic problems in the GIT section. Diaphragm separates the chest cavity from the abdominal cavity. I'm talking about the Bochtelecke hernia. We'll see that soon inshallah. Then we have abdominal wall defect that is present on the right side of the umbilicus. Intestines herniate outside the abdominal cavity. Okay, and then here the heart and lung and the umbilical cord is present just intact, right in place. Here you can see that the herniated loops of intestine are present like that. The abdominal wall defect to the right side of the umbilical cord. The umbilical cord is looking like that, and the left rectus muscle, that is left rectus muscle is just intact. The problem is with the right rectus muscle and the intestine within the abdominal cavity. So some intestine is present inside the abdominal cavity while some of it is herniating outside. Now let's move to the next picture. Congenital umbilical hernia. So failure of the umbilical ring to close after the physical herniation of the intestine, after the physiologic herniation of the intestine. So umbilical ring, basically the problem is that umbilical ring normally closes after the gut is retracted back into the intestine. Like on the 10th week, when the gut returns back to the intestine, the umbilical ring constricts or it closes. If this ring does not close, this can give rise to umbilical hernia, and small defects usually close spontaneously. I guess there is a picture of that. There is no picture, so let's see a picture over here. Umbilical hernia. So this is a picture of umbilical hernia over here. Yeah, this looks something like that. There's a very gross picture, but it looks something like that. Like the problem is with the lack of closure of the umbilical ring. Then let's come back. Tracheoesophageal anomalies, very high yield concept. Esophageal atresia with the distal tracheoesophageal fistula is the most common, 85%, and often present with a polyhydramnios in utero due to the inability of the fetus to swallow the amniotic fluid. Now the problem is, the basic mechanism is that during the embryonic life, suppose this is the common tube for the respiratory and the esophageal epithelium. The respiratory and gut epithelium, there is a common tube for that. The lungs deviate from that, the lungs herniate and they form the trachea. And there is initially, the point I want to highlight is that initially there is a connection between the esophagus, the primitive esophagus and the primitive trachea. After some time, the trachea gets separated from here, and that separation, the trachea gets separated, and when the trachea has been separated, so resultantly what do we expect, that esophagus and the trachea are two separate tubes, and the trachea is developed anterior to the esophagus, and then these structures will form the lungs and stuff like that, and there will be a beautiful picture. But if there is some kind of connection that is left between the trachea and esophagus, that is called as tracheoesophageal fistula. And the basic concept of fistula is that the two luminal cavities, like there is a luminal tube like that, and then there is another luminal tube, both of them are connected together. This is the basic science we follow in the case of fistula. So now let's see it. Over here are the neonates. Esophageal fistula, like this one is the most important, most common type of esophageal fistula, in which the esophagus, the proximal esophagus becomes atretic. There is just a closed pouch, and the distal esophagus is continuous with the trachea. So this kind of tracheoesophageal fistula is very common, and it is seen in the 85% of the cases. Now suppose this is the fetus like this, and it is surrounded by the amniotic fluid, and then there is an amniotic membrane and stuff like that. So from where is the amniotic fluid coming? The amniotic fluid is basically the urine of the fetus, right? So the fetus urinates and it becomes amniotic fluid. then this amniotic fluid is swallowed back by the fetus itself. The fetus swallows the amniotic fluid, it goes back and it is absorbed into the fetus and stuff like that, and then it comes back as urination. So there is a cyclical activity that is going on inside the amniotic cavity that keeps the level of, that keeps the amount of amniotic fluid in check. But in this condition, suppose that we are talking about this very condition, and in this particular situation the esophagus is atretic and nothing can enter the body of the fetus via mouth, right? Because esophagus can there is no opening of the esophagus leading to the stomach or intestines, so there is no entry of the amniotic cavity, amniotic fluid into the fetal body. So the only thing that is happening now is the urination. So fetus urinates more and more amniotic fluid into the cavity, but none of that is being reabsorbed. So resultantly there is polyhydramnios and the amniotic sac becomes very big, like that. There is a very big amniotic sac, and this is the concept of polyhydramnios. So here you can see that the neonates drool, choke and vomit with the first feeding, and this tracheoesophageal fistula becomes very evident early on in life when the mother tries to feed the baby and the baby starts drooling, and then you try to pass the endotracheal tube inside the baby, and the tube cannot be passed. So resultantly the problem is with the tracheoesophageal fistula. The tracheoesophageal fistula allows the air to enter the stomach, visible on chest X-ray. The tracheoesophageal fistula will allow the air. Okay, so normally the air is present inside the okay. So normally the air is present inside the stomach, but to a smaller extent. But with the tracheoesophageal fistula, a large bubble of air can be seen inside the stomach. Why? Because the distal part of the esophagus is continuous with the trachea, and the air that will enter the trachea after the child is born, it will go into the stomach, and an air of bubble can be seen inside the stomach. Let me show you a picture of that in the first year 2022. Now here you can see that normally there is a gastric bubble. Gastric air bubble is a smaller bubble that is present in the stomach, right? If there is a tracheoesophageal fistula like that, or maybe like this H-shaped fistula, the gastroesophageal bubble becomes larger. The air bubble inside the stomach is like too big. But in the case of this complete or pure esophageal atresia, like there is no fistula, the only thing we are seeing is the atresia of the esophagus. In that case, we don't find any kind of air in the stomach, because this air bubble is coming via esophagus. When you are eating something, so esophagus is not an airtight tube. Or it is airtight, but I'm just trying to tell you that when you ingest something, air also enters the esophagus, and that air can go into the stomach as well. You experience that when you belch, right? In the belching activity, you know that air is coming from the GIT, right? So that gastric bubble can be found, but in case of tracheoesophageal fistula, that gastric bubble enlarges, or that becomes bigger, like that. Now let's come back to our PDF. So here you can see this is the most common type, but there are other types as well. So neonates drool and choke with the first feeding tracheoesophageal fistula allow the air to enter the stomach that is visible on the chest X-ray. Cyanosis is secondary to the laryngospasm to avoid the reflux-related aspiration. The clinical test is failure to pass the nasogastric tube into the stomach. So what is the concept of laryngospasm? Like, okay, we understood that something from the trachea like air can go into the stomach, but definitely things from the stomach can also come back into the trachea. And this can result in a chemical pneumonia, and the most common cause of death, and as well as a very common presentation in the people with the tracheoesophageal fistula is the chemical pneumonitis or chemical pneumonia. The thing that happens is the HCl and the pepsinogen that is present in the stomach that is drooling back into the esophagus, and from the esophagus, since esophagus is connected to the trachea, so stuff from the stomach can go back into the lungs. So that will cause chemical pneumonia. So they were saying that laryngospasm. So when there is reflux of the chemical irritants from the stomach into the trachea, the muscles of the trachea and the larynx, they become constricted, and when they are constricted, so resultingly there is a laryngospasm, and that laryngospasm will cause cyanosis. Like nothing can enter the trachea now, because trachea has been constricted. Air will not be able to enter the trachea, and resultingly the person will suffer from cyanosis. In H-type fistula resembles letter H. In pure esophageal atresia, chest X-ray will show gasless abdomen. So this is the H-type. Like esophagus is continuous. Esophagus is not atretic. Esophagus is patent, but it is also connected to the trachea. So like this is H-type tracheoesophageal fistula. Then we have pure esophageal atresia, in which the esophagus has become atretic and it is not connected to the stomach, neither to the trachea. So in this particular scenario, we will get a gasless stomach, as we have seen in the FA 2022, and this is a normal anatomy. Now let's move forward to the intestinal atresia. The intestinal atresia, it presents with a bilious vomiting and abdominal distension within 1 to 2 days of life. There are two types of atresia which are clinically significant. First one is duodenal atresia, and second one is the jejunal or ileal atresia. The duodenal atresia, the problem is that the duodenum there is a failure of the duodenum to recanalize. It is associated with double bubble sign, dilated stomach, proximal duodenum on X-ray. So dilated stomach and proximal duodenum on X-ray associated with the Down syndrome. So duodenal atresia is associated with the Down syndrome. There are very few conditions in the GIT which are associated with the Down syndrome, and one of them is the duodenal atresia. Now let me tell you how the duodenal atresia looks like. So duodenal atresia is something like that. If you draw it like this, and you know, so duodenal atresia, the problem is that normally the duodenum is a tube, a luminal tube. The cells of the duodenum, they start proliferating, and when they're proliferating, they fill the duodenal luminal tube, and that is a physiological process that is happening in the normal embryological events. These cells which have filled the luminal tube, fill the duodenal tube, they are supposed to be they are supposed to vanish in the long run, and then the duodenum will be recanalized. If the recanalization does not occur and the duodenum is still atretic, so this can result in duodenal atresia. And now, if the atresia or the duodenal obstruction, like suppose this is the esophagus, and then we have the stomach, and after the stomach we have duodenum like that, and the major papilla which contains the pancreatic or duodenal duct, it is entering the second part. If the atresia is happening like over here, distal to that, so there will be bilious emesis, and mostly it is bilious emesis that is seen most commonly with the duodenal atresia. So we say that it is so we just assume that the obstruction is distal to that. But just for a conceptual purpose, if the obstruction is residing over here, so in this particular scenario, since the entry of the bile is distal to the point of obstruction, the emesis will not be bilious, the emesis will not be green, right? But just forget about this point. Normally the atresia is happening over here, or the problem is distal to the entry of the pancreatic or duodenal duct. So the bile is entering the duodenum but cannot reach the small intestine, like not the jejunum or ileum, so resultantly it refluxes back, and the child is having bilious emesis. So this is the concept of non-recanalization in the case of duodenum. There is another point of intestinal atresia that is happening in the jejunum or ileum. So that is called as jejunal or ileal atresia. Disruption of the mesenteric vessels leads to ischemic necrosis and segmental resorption, bowel discontinuity of the apple peel sign. Okay, so there was a just give me a second. There is a double bubble sign. Let me show you a double bubble sign over here. The double bubble sign looks something like that. Double bubble sign. So the double bubble sign is something like this. Like there is a stomach, bubble in the stomach and bubble in the proximal duodenum. If I could draw it over here. So the thing that is happening is that the stuff that the baby is being fed with, like the milk or something like that, that is accumulating inside the stomach. And then there is a pylorus, where there is a pyloric sphincter. There is a constriction, like skeletal muscle is present over here, and there is a constriction. A sphincter is present over here. I don't think it is skeletal muscle; it is smooth muscle, but there is a sphincter. And then there is a distal duodenum that is patent, and after that there is an atresia. So due to this pyloric sphincter, we find a bubble over here and a bubble over here. So this thing is called a double bubble sign that we find with the duodenal atresia. The second problem is with the jejunum, and that gives us the apple peel appearance. Apple peel appearance. So apple peel appearance looks something like this. Like this. It's not a very obvious picture, obvious finding, but something on those lines. Like you can assume it to be an apple peel like that. So the problem with this jejunal or ileal atresia is that there is a mesenteric disruption of the mesenteric vessels, and when there is disruption, why will there be disruption? Suppose we are talking about malrotation, like or volvulus. Like in these particular scenarios, there is a obstruction of the vessel, and the vessel, if that is obstructed, that will result in ischemia. And if there is ischemia, so the embryological development of the GIT at the level of jejunum and ileum will not take place, and resultantly these segments will become atretic because of ischemic necrosis. Segmental resorption. Okay, so there is segmental resorption, bowel discontinuity, or there will be an apple peel appearance. Then we have intestinal atresia that is happening at three levels. Number one is duodenum, second is jejunum or ileum, and third is the colonic. So the pathophysiology of the duodenum is the failure of recanalization at 8th to 10th week of gestation. The clinical finding is the bilious or non-bilious emesis. There is a double bubble sign on chest X-ray, and the association is with the Down syndrome. The jejunum or ileum, the problem is with the vascular injury. The clinical findings are bilious emesis and the abdominal distension, and associations are gastroschisis. The problem with the colonic atresia is the pathophysiology is unknown. Findings are constipation and abdominal distension, and associations are Hirschsprung disease. So here you can see that apple peel atresia, I guess proximal jejunal pouch and apple peel appearance is happening like that. Maybe I'm not sure. And no, this is apple peel appearance. Like it is also apple peel, and this is also an apple peel appearance. Okay, so terminal ileum, terminal distal ileum, it looks something like an apple peel. If you are, if you are a master of peeling off the apple and you, scrub it off like that. So this is a classic apple peel appearance which is depicted over here. This is the double bubble sign, and you can see a double bubble sign over here as well. So nasogastric tube is inside the stomach. Then this is a, stomach bubble, and there is a proximal duodenal bubble. And if I could zoom it in, so we can see what is written in the red. They are saying that there is an absent distal intestinal gas. So there is a gas in the stomach, there is gas in the proximal duodenum, and there is no gas anywhere else because of the atretic duodenum. This is the concept of double bubble sign. Then let's move forward to the hypertrophic pyloric stenosis. So hypertrophic pyloric stenosis is the most common cause of the gastric outlet obstruction in the infants, like 1:600. Palpable olive shaped mass. It is a very important buzzword which they often give you in the questions time. They will give you the buzzword that there is a palpable olive like mass in the epigastric region. So you have to go for the pyloric stenosis in that particular case. Visible peristaltic waves and non-bilious projectile vomiting at 2 to 6 weeks old. So hypertrophic pyloric stenosis, if it is congenital, because there are situations when it is not congenital, but if it is congenital, in those scenarios, it is visible only 2 to 4 weeks after, or 2 to 6 weeks after the birth, because it is not a problem with some kind of it is not a problem of obstruction or atresia. The problem is hypertrophy, and hypertrophy takes time. The muscle is becoming hypertrophic, and that will take 2 to 4 or 2 to 6 weeks after the birth, and after that there will be signs and symptoms of hypertrophic pyloric stenosis. It is more common in the firstborn males, associated with exposure to macrolides. Result in the hypocalemic, hypochloremic metabolic alkalosis. Why hypocalemic, hypochloremic? Because suppose, like in the case of let me come on the Canva. So here you can see that, like, suppose this is the stomach, and we are saying that there is pyloric stenosis. So for the stomach, remember these sites, like this is the cardia, this is fundus over here, then we have body, then before body we have this antrum, and this is pylorus, and there is the pyloric sphincter over here. So the problem in these infants is that there is pyloric hypertrophy. When the pyloric hypertrophy is there, the content that was present in this region, that is what is present in this region, the major content present in the stomach is the HCl, and the major content that is present in the stomach is HCl, and the other thing is the pepsinogen. So we'll talk about HCl. Like HCl is present over here, and if the child cannot ingest anything, the child will have emesis, non-bilious emesis. And because the bile is entering at this point and there is an obstruction proximal to that, so the emesis will be non-bilious. And if there is non-bilious emesis, the chloride ions will be lost from the body. So there will be hypochloremia. Why is there hypokalemia? Because hydrogen ions are also being lost, and okay, that does not make sense to me. Why is there hypokalemia? There is hydrogen potassium ATPases, potassium enters the cells, and hydrogen is leaving the cells. Never mind, I just don't remember what is the concept of hypokalemia over here, but there will be hypochloremia for sure because HCl is being lost. Then we have hypokalemia, hypokalemic, hypochloremic metabolic alkalosis will be there because acid is being lost from the body, secondary to the vomiting of the gastric acid and subsequent volume contraction. Okay, there is volume contraction, and whenever there is volume contraction, so due to the volume contraction in the distal convoluted tubule, like suppose this is the nephron, and in the collecting duct we have principal cells. And in the principal cell, whenever there is volume contraction because of the excessive vomiting, the principal cells will be activated by the aldosterone, and aldosterone is a potassium waster. So ultimately the chloride is being lost from the stomach and the potassium is lost from the kidneys. So we get hypokalemic, hypochloremic metabolic alkalosis in the case of pyloric stenosis 2 to 6 weeks after the birth. This timeline is very important, that is happening 2 to 6 weeks after the birth. Ultrasound shows thickened and lengthened pylorus. Like if I could zoom this picture, so this is an ultrasonography in which you can see the pyloric wall, and then pyloric channel is like that, I guess. And okay, so this whole thing is pylorus, and this pylorus has become lengthened and also thickened, something like that. Like this is this whole thing is the wall of pylorus, and that has been thickened. Now you can see that the treatment is surgical incision, that is called as pyloromyotomy. We incise the muscles of the pylorus. So we know that the problem is that muscles have become hypertrophic, so we cut those muscles, and when we remove the muscle, the problem is theoretically solved. Now you can see the hypertrophic pyloric stenosis as they have depicted. Like this is the normal pylorus, and if it becomes hypertrophic, so it looks something like that. And this is not an olive-like mass, but you know that there is distension of the stomach or something like that, because there is pyloric stenosis maybe. Moving forward to the point, Uworld point is cases 2 day neonate with bilious vomiting and laparotomy shows absence of the large segment of small bowel and distal ileum winding around the vascular stalk. What is the problem? It is an apple peel atresia due to the vascular occlusion of the superior mesenteric artery. There is an NBME point that jejunal, ileal and colonic atresia are not caused by the abnormal fetal development. They are not congenital abnormalities. Remember that. Jejunal, ileal and colonic atresias are vascular accidents in utero, as we have seen in this picture, that although the cause of colonic atresia is not very well known, but for the jejunum and ileum it is vascular injury. So the jejunal, ileal and the colonic atresias are not caused by the abnormal fetal development. They are not congenital malformations. They are due to vascular incidents in utero, like during the intrauterine life there is some sort of vascular accident, and that results in the atresia of these segments of the GIT. There will be decreased perfusion. There will be ischemic segment absent, blind pouch, blind and proximal jejunum. So the ischemic segment is absent, that will result in the blind and proximal jejunum. Distal segment, spiral configuration around the ileocolic vessel, mostly the ileum, and apple peel or Christmas tree deformity. So here you can see that these jejunum must be continuous with the ileum like that. Now the segment between this and this is gone, that has been resolved, and there is proximal jejunal pouch. The proximal end looks like that, and the distal end is making a Christmas tree like appearance, or maybe you can also call it like apple peel appearance, and this is the terminal ileum distal to the atresia. Now let's talk about the pancreas and spleen embryology. The pancreas is derived from the foregut. Remember, the pancreas is coming from the foregut. The foregut is starting from the oral cavity, going down all the way to the duodenum in the second part till the major papilla. We have discussed that. So the pancreas is derived from the foregut. The ventral pancreatic bud contributes to the uncinate process and the main pancreatic duct. Okay, so this is the uncinate process coming from the ventral pancreatic duct, and this is the main pancreatic duct. Both of them are arising from the ventral pancreatic bud. I guess there is a picture of that. No, there is no picture. But the pancreas is coming from the two buds. One bud is like this. This is the dorsal bud, and this is the ventral bud. So in the adult, this ventral bud has given rise to the uncinate process and this main pancreatic duct, while the dorsal duct is giving rise to, let us see that, the dorsal pancreatic bud alone becomes the body, the tail, the isthmus and the accessory pancreatic duct. So the body, which is over here, the body, then there is an isthmus over here, then there is a tail like that. So body, isthmus, tail and the accessory pancreatic duct, all of these structures are coming from the dorsal bud of the pancreas. Both the ventral and dorsal bud of buds contribute to the pancreatic head. Like this whole thing is the head, including the uncinate process. So the dorsal and the ventral, both of these processes are helping in the formation of the pancreatic head. And you must remember that it is the pancreatic head that is the most common site for the development of adenocarcinoma of the pancreas. We'll see that in detail in the pathology session, inshallah. What is annular pancreas? The abnormal rotation of the ventral pancreatic bud forms a ring of the pancreatic tissue. It encircles the second part of the duodenum and may cause duodenal narrowing and vomiting. As you can see in this picture, that's the ventral bud which was supposed to wind, like this is the ventral bud. Here you can see the ventral bud. It was supposed to come, and join the dorsal bud behind the duodenum. But if it encircles over the duodenum and comes and join like that, so there will be constriction of the duodenum in this region of the overlap by the ventral segment, and this is the thing that we call the annular pancreas. So it encircles the second part of the duodenum and may cause the duodenal narrowing and thus vomiting. And then we have the pancreatic divisum. The ventral and dorsal parts fails to fuse at 8 weeks. So the pancreatic divisum is like the dorsal, like forget about this thing. Like it is the dorsal part and the ventral part. If both of them do not fuse together, so this part will remain over here and the second part will remain over here, and they're good to go with that. The people are mostly asymptomatic. The pancreatic divisum is the ventral and dorsal parts fail to fuse at 8 weeks. Common anomaly, mostly asymptomatic but may cause chronic abdominal pain and or pancreatitis. Spleen arises in the mesentery of the stomach, hence it is mesodermal, but has foregut supply, celiac trunk and sphenic artery. So spleen, it is derived from the mesoderm, but the blood supply is coming from the foregut. We'll see that the foregut, midgut and hindgut, all of them have different blood supply. The foregut is being supplied by the celiac artery. The midgut is, there will be a table later on, but the foregut is supplied by the celiac artery, the midgut is supplied by the superior mesenteric artery, and the hindgut is being supplied by the inferior mesenteric artery, right? The hindgut is supplied by the inferior mesenteric artery. Now, the problem is that no, it's not a problem, it is a fact that the spleen is arising from the mesoderm, but it is being supplied by the celiac artery, which is a blood supply of the foregut, and it is also present in the foregut. So that is, you know, the branch of the celiac artery, the splenic artery supplying the spleen. You'll see that in detail later on. So here you can see this is the stomach, and then what's that? I don't know, I guess they are trying to depict the annular pancreas or something. Here you can see the gallbladder, the accessory pancreatic duct which is coming from the dorsal bud. Then we have the minor papilla. The accessory duct opens into the minor papilla and the duodenum, and the pancreatic or duodenal duct, the main pancreatic duct, opens in the major papilla, and this major papilla marks the termination of the foregut, and after that the midgut starts. Then we have the pancreatic bud, the dorsal one. No, it's pancreatic duct. I'm sorry, the main pancreatic duct. Then the dorsal pancreatic bud is over here. Then the main pancreatic duct is like, you know, this pancreatic duct comes down, and the duct which is present in the uncinate process that fuses with that, and that forms the main pancreatic duct and stuff like that. Okay, then we have, you know, uncinate process, and you will point about the annular pancreas, abnormal migration of the ventral pancreatic bud, usually asymptomatic, but may present with an intestinal obstruction or pancreatitis. There is also Uworld point about the ventral pancreatic bud is composed of the main pancreatic duct and uncinate process. The ventral pancreatic bud is composed of the main pancreatic duct and the uncinate process. So these two things are going to form the, they are going to come, they are arising from the ventral pancreatic bud, the main pancreatic duct and the uncinate process. The ducts of the pancreas. What is meant by that? So let's see, there are a lot of ducts in the pancreas. The first one is the main pancreatic duct that runs along the long axis of the pancreas from the tail to the head. Like it is coming from the tail, like this is, suppose, let me delineate the organs. You know, this is the tail, this narrow portion is the isthmus, and then we have the body, and then there is an uncinate process. So tail, isthmus, body, and the uncinate process. So the main pancreatic duct runs along the long axis of the pancreas from the tail to the head. It is running from the tail all the way to the head of the pancreas. This whole thing, along with the uncinate process, I guess along with the uncinate process, is the head of the pancreas. Then accessory pancreatic duct, it runs horizontally, opens into the top of the minor duodenal papilla, which is about 2 cm proximal to the major duodenal papilla on the posteromedial wall of the duodenum. Okay, so there is the bile duct like that, and accessory pancreatic duct is looking like this. Like this is the accessory pancreatic duct opening in the minor papilla. Let me change the color. So here you can see that the accessory pancreatic duct, this one, it is opening into the minor papilla, while this main pancreatic duct is opening along with the common bile duct into the major papilla, and that is called the hepatopancreatic ampulla because it has hepatic component like the common bile duct and the pancreatic component. So this is called the hepatopancreatic ampulla, the major duodenal papilla and the minor duodenal papilla and stuff like that. Now let's move forward to the next point. What is pancreatic divisum? We have seen that. Let's see that once again. The pancreatic divisum, it is the failure of fusion of the ventral and dorsal pancreatic buds. The pancreatic ductal system remains separate with the accessory duct draining majority of the pancreas. So the accessory duct will be draining majority of the pancreas, like when the ventral and pancreatic duct have not fused with each other. So this is the accessory, like this is, you know, how is it pancreatic divisum? I don't know, but it is the accessory duct that is draining most of the pancreas, and the ventral duct is present, ventral bud is present like this maybe, or sometimes along with that, but they are not fused together. So the majority of the pancreas is being drained by the accessory pancreatic duct, the bile duct, duodenum and stuff like that. So even in this picture you can see that the bile duct, although it is fusing with this major duct, but this duct is draining only this much of the pancreas, while most of the pancreas is being drained by the accessory duct, including the head, the body, the isthmus and the tail. All of these things are being drained by the accessory papillary duct, and a very small portion of the pancreas along with the common bile duct, both of them are draining into the major papilla by the main pancreatic duct. In the case of pancreatic division, there is the Uworld point. The case is that there is distended air-filled stomach that narrows at the level of proximal duodenum and then dilates again. That is the double bubble sign. That can be seen in the case of duodenal atresia, also in the case of annular pancreas. So these are the two conditions that can create the double bubble sign. Most commonly they associate that with the duodenal atresia, but the double bubble sign can also be seen in the case of annular pancreas, because in both the conditions the problem is with the duodenal obstruction, and if the duodenum is obstructed, so we can get the double bubble sign. So the double bubble sign, it is seen in the duodenal atresia within hours after birth, and in the case of annular pancreas, any time between the infancy and the adulthood, or maybe not at all, like maybe the annular pancreas is not causing any kind of duodenal obstruction. Yep. So double bubble sign is a very characteristic finding in the duodenal atresia. It can also happen in the annular pancreas. Then there is the Uworld point, the organ that has blood supply from the foregut but is not a foregut derivative. Like foregut is endoderm derivative, so that kind of thing is the that thing is a spleen. So spleen or the mesoderm is spleen is a mesoderm derivative, but it's supplied by the blood supply of the foregut, that is celiac artery. Spleen is the most common intra-abdominal organ to be injured after a blunt trauma. Spleen is coming from the mesoderm, liver is coming from the endoderm, pancreas endoderm, and kidney is also from the mesoderm. So spleen and kidney, they are originating from the mesoderm, but the liver and pancreas, they are originating from the endoderm. Remember that. Now here you can see Wittline duct. The Wittline duct is at the 7th week. Obliteration of the Wittline duct, omphallomesenteric duct, which connects the yolk sac to the midgut lumen. Like there is that, Wittline duct or the omphalloenteric duct is a connection between the yolk sac and the midgut lumen, and it gets obliterated at the 7th week of gestation. But if it persists, so it can cause Wittline fistula or maybe Macus diverticulum. So Wittline fistula, like over here, so it is a condition in which the Wittline duct fails to close and meconium discharges from the umbilicus. Like suppose that if I could draw it over here, so they are saying that this is the midgut. Midgut contains the duodenum, jejunum, and ileum. So suppose we are talking about ileum. So here is the ileum, and the omphallomesenteric duct was supposed to connect this to the yolk sac. Like yolk sac is external to the, it is present outside the umbilicus. So this is very gross kind of embryology, but when the fetus is developing, like suppose this is the fetus, the yolk sac is hanging out like that. It is coming out of the fetus. So it is the omphallomesenteric duct. Omphallomesenteric is the Wittline duct which is connecting the yolk sac with the midgut lumen, right? And normally in the 7th week of gestation, normally at the 7th week of gestation, that gets involuted. Like this omphallomesenteric duct, this becomes obstructed. Now if it does not get obstructed and there is a patent connection between the midgut lumen and the outside environment, so resultantly there will be drainage of the meconium from the umbilicus, and that is a very gross presentation, but this is a condition that we see in the case of Wittline fistula. The second condition is the Macus diverticulum. There is a partial closure of the Wittline duct with a patent portion attached to the ileum, true diverticulum, may have heterotopic gastric or pancreatic tissue that may cause melena, hematochezia, or abdominal pain. So the problem is that, as you can see in this picture, that in the first picture we saw about the Wittline fistula, that there is a patent connection between the midgut lumen and the umbilicus, and the meconium can drain from that. In the case of Macus diverticulum, there is a fibrosed connection between the umbilicus and the and the midgut lumen, and there is a true diverticulum coming out of the midgut, mostly from the ileum, and this thing is called the Macus diverticulum. Normally it is asymptomatic, but if it contains heterotopic mucosa, like heterotopic means mucosa or the mucosa from some other organ, like we are talking about the mucosa of maybe stomach or maybe small intestine, maybe other portions of the intestine. So if it is containing the mucosa of the stomach, so that mucosa of stomach is responsible for the secretion of HCl and pepsinogen and stuff like that. So if there is heterotopic mucosa coming from the stomach, it may result in the melena, in the hematochezia and abdominal pain. So melena is a dark tarry stool, the hematochezia is a bright red blood that is seen in the stool, and the abdominal pain is the abdominal pain. So suppose, why is there melena? The blood contain RBCs, RBCs contain hemoglobin, right? If the hemoglobin is exposed to the HCl, like if there is exposure of HCl to the hemoglobin, the heme component will be broken down into hematine, I guess, or something, but it becomes oxidized and or it becomes degraded, and the heme, if it is degraded, it becomes black. So that will give us black tarry stools, that is called as melena. And hematochezia is like if there is no exposure of the blood to the HCl, or if the bleeding is occurring distal to the duodenojejunal junction, like DJJ, if the bleeding is happening distal to the DJJ, duodenojejunal junction, so normally there is no exposure of the HCl distal to the duodenojejunal junction. So in those particular scenarios we get the hematochezia. So here you can see persistent Wittline duct, like it is a very good picture, I guess they have taken it from Uworld. So in this scenario, the meconium that is being formed here will be draining outside. This is the Macus diverticulum, in which we have a true diverticulum, but it is not connected to the umbilicus. There is a fibrosed, fibrous band is connecting the umbilicus to the Macus diverticulum. Then we have Wittline sinus, in which it is the opposite of the Macus diverticulum, like the sinus is present over here, and it is connected with the fibrous band to the midgut, and it may become infected, and then there will be sinus drainage and stuff like that. And there is a Wittline cyst or enterocyst, in which the Macus diverticulum it is closed at ends, and it is patent in the midline, and that cause the formation of a cyst. Then we have Uworld point, abnormal omphallomesenteric duct obliteration result in. We have seen that, but now let's talk about that once again. So abnormal omphallomesenteric duct obliteration will result in a persistent Wittline duct or Wittline fistula that occurs due to complete failure of the Wittline duct to close. A small connection between the intestinal lumen and the outside of the body exists at the umbilicus. Meconium discharge from the umbilicus is seen soon after birth in the first case, like the persistent Wittline sinus. The second scenario is with the Mecus diverticulum. It is most common Wittline duct abnormality. It results from a partial closure of the Wittline duct with the patent portion attached to the ileum. Like the patent portion is attached to the ileum. So that is Mecus diverticulum, and that is the most common Wittline duct anomaly. With the patent portion attached to the ileum, a fibrous band may be connected to the tip of the Mecus diverticulum with the umbilicus. What is Wittline sinus? The result in the partial closure of the Wittline duct with the patent portion open at the umbilicus. It is exact opposite of the Mecus diverticulum. In the Mecus diverticulum, the fibrous band is attached to the umbilicus and the patent portion is attached to the ileum. In the case of Wittline sinus, the patent portion is attached to the umbilicus while the fibrous band is attached to the ileum. Then here you can see Wittline duct cyst or enterocyst forms in the peripheral portion of the Wittline duct connected to the ileum and umbilicus, obliterate but the central part remains. The cyst is connected with the ileum and abdominal wall by the fibrous bands. Now here you can see we have Mecus diverticulum. True diverticulum, there is a persistence of the Wittline duct may contain the ectopic acid secreting gastric mucosa, the ectopic mucosa, the heterotopic mucosa if it is coming from the stomach. So that will be acid producing definitely. Most common congenital anomaly of the GIT. It can cause melena, the right lower quadrant pain, and intussusception. We'll talk about intussusception, but basically the basic concept of intussusception is the telescoping of the intestine. Like suppose this is an intestine and the proximal intestinal lobe is telescoping inside that, like this. So this is the concept of intussusception. And the Mecus diverticulum, like there is a diverticulum which can act as a lead point, because it is a lead point which is very important in the case of intussusception, and Mecus diverticulum can act like one. Then we have a propensity of volvulus, obstruction near the terminal ileum, contrast with the omphallomesenteric cyst, cystic dilation of the Wittline duct, like this thing, cystic dilation of the Wittline duct. Then we have diagnosis is with the pertechnetate study for the uptake of ectopic gastric mucosa. The 6 toes. For the Mecus diverticulum, you must remember these toes. It is 2 times more likely in males. It is 2 inches long, 2 feet from the ileocecal valve. 2% of the population is affected, and commonly present in first 2 years of life, and may have 2 types of epithelia, like the gastric or maybe the pancreatic or stuff like that. So here you can see the small intestine. So Mecus diverticulum is a true diverticulum. When do we call something a true diverticulum? Like all the 3 layers, like all the four layers are herniating outside. The main layers are the mucosa, the submucosa, the muscularis and serosa, and this pattern is followed throughout the GIT. If all the layers are herniating outwards, this is called as a true diverticulum. For example, the Mecus diverticulum. It is one of the very few true diverticulums in the body. Okay. And the second scenario, the muscularis and the serosa are intact, or the muscularis is not herniating, and the mucosa and submucosa are herniating outwards. And this particular scenario is called as a false diverticulum, and this is seen in the case of Zenker's esophageal diverticulum and common colon tics. I guess there are some kind of colonic fistulas, and those are also false diverticulum. But the true Mecus diverticulum, the true diverticulum, you must remember that. There is a Uworld point about the Mecus diverticulum. What is the cause? The failure of obliteration of the omphallomesenteric duct. The clinical presentation is lower gastrointestinal bleeding is one of the most common presentation of the Mecus diverticulum. This diverticulum contains ectopic gastric mucosa, which produces acid causing possible ulcerations and bleeding. 99 mm technetium pertechnetate scan identifies the ectopic gastric epithelium and helps diagnose the Mecus diverticulum. When a Mecus diverticulum becomes inflamed, the clinical appearance is almost impossible to differentiate from the acute appendicitis. Like suppose the Mecus diverticulum was present on the right side at the ileocecal junction, and that is very close. Like suppose the ileocecal junction is like that. This is the ileum, then we have the cecum which is like that, and this is the ileocecal junction, and here is the appendix. So if the Mecus diverticulum is present at the ileocecal junction and the appendix is also present over here, appendix is alright, but this became inflamed. Now it is in very close proximity to the appendix, so when we do the ultrasound, it is almost impossible to differentiate the Mecus diverticulum, inflamed Mecus diverticulum, from the acute appendicitis, because the symptoms and everything is just similar to the acute appendicitis. The diverticulum may itself also predispose to the intestinal intussusception, which manifests as a colicky abdominal pain and current jelly stool, because there is bleeding inside, and that bleeding will go and enter the stool, and then the stool will look like current jelly and stuff like that. If you've never seen current jelly, it looks like a fine strawberry jam. So the current jelly is a fine strawberry jam. We'll see this buzzword quite a few times in the step 1 studies in this book. So the current jelly looks like a strawberry jam. What is Hirschsprung disease? This is the situation which is said that was very closely associated with the Down syndrome. Now there are two situations in the whole GIT that are associated with the Down syndrome. The first one is the duodenal atresia, and the second one is the that thing that we call the duodenal atresia and the Hirschsprung disease. And there is another condition that we call the congenital umbilical hernia is also associated with the Down syndrome. We have seen that it was written the 1st of 2022, not in this book, but so you can remember that the third condition associated with the Down syndrome is the congenital umbilical hernia. Now let's come back to this picture, this discussion. So in Hirschsprung disease, the abnormal migration of the neural crest cell to the intestinal wall. The problem is that the neural crest cells have not migrated to the intestinal wall. It is characterized by the absence of the parasympathetic ganglion cell in the segment of the colon. The denervated area is narrowed, causing the symptoms of intestinal obstruction and encouraging the compensated dilation of the proximal segments of the bowel. Since the neural crest cells migrate caudally, the rectum is always involved in the Hirschsprung disease. Okay. Yeah. So the rectum is always involved in the Hirschsprung disease. The problem is that suppose the neural crest cells. Let me show you what the neural crest look like normally. Suppose this is the ectoderm. I'm not making individual cells, but this is ectoderm. I guess like this. Okay, this is cool. So this is ectoderm, and then we have endoderm like this, and this, and the mesoderm is surrounding like this area. Like these are the mesoderm. The somatic and the splanchnic mesoderms are like that. The somatic and splanchnic mesoderms. Don't go in the detail of that because we're not concerned with that right now. The neural tube that is present in the middle of all of that, we have the neural tube which looks something like this. Like there is the neural tube, below that is the notochord, and above that we have the neural tube, and surrounding the neural tube we have neural crest cells like this. So neural crest cells, they give rise to a lot of structures, and we'll study those structures in detail when we do the repro unit inshallah. But for right now, remember that these neural crest cells give rise to the ganglion cells which are present in the myenteric plexus or the Auribac plexus. Now what are the concept of plexuses in the case of GIT? Like suppose this is the mucosa, then we have submucosa, not submucosa, then we have lamina propria, and then after lamina propria we have submucosa, and then then after submucosa we have the muscularis propria, and then serosa, right? So these are the main layers, like mucosa, the submucosa, the muscularis propria, and there is another thing that is the serosa, right? So the nerve plexus that is present between the mucosa and submucosa, this nerve plexus that is present between the mucosa and submucosa over here, this plexus is called as a submucosal nerve plexus, right? It makes sense because it is present under the mucosa. So this is submucosal nerve plexus or Meissner's nerve plexus. And the nerve plexus is present between a submucosa and muscularis. This nerve plexus is called as a myenteric nerve plexus or Auribac nerve plexus. It is a myenteric or Auribac. So you can it also makes sense. Like since it is present, since the Meissner plexus or the submucosal plexus that is present just below the mucosa. And what is the function of mucosa? The function of mucosa is to perform the secretion and stuff like that. So if there is problem with this plexus, so the problem will be that the mucosa is not producing enough secretions, right? We are not talking about that right now. If the myenteric plexus or the Auribac plexus is deficient, it is present just below the muscles. So it was supposed to cause the contraction of the muscles or maybe the relaxation of muscles, right? So if the ganglion cells which are responsible for the relaxation of the muscle, they are not present. So resultantly what do we get? We get constricted abdominal segments. Now if we draw GIT like this is the esophagus, and then we have the stomach, and after the stomach we have the intestines, and intestines are like that, and then after the intestine we have the large intestine, then large intestine becomes the rectum, and like this. So if the neural crest cells are descending downwards from the head, from the cranial end to the caudal end, So they're descending downward, and if they're descending downward, they will involve the esophagus, then stomach, then they will cause innervation of the small intestine and large intestine. So whenever there is Hirschsprung disease, we are saying that there is abnormal migration. The structure that will always be involved in the rectum, because that's the last structure to be innervated. If there was abnormal migration, we don't know the extent of the abnormality of migration, but we know that if there was abnormal migration, so the last region is definitely not innervated, and that is rectum. So that is why we say that the rectum is always involved in the case of Hirschsprung disease. The absence of ganglion cell in the colonic wall causes the affected segment to be narrowed because it cannot relax. Now, the problem is that suppose I'm talking about a particular segment. This is a segment of the rectum, or maybe the sigmoid colon, or maybe the descending colon that was not innervated. So this becomes narrowed, and the food or the feces that is coming from here, that starts piling proximal to that. So the proximal segment becomes enlarged. So that the problematic segment is this one, which is narrowed, and proximal to that we have the dilation of the segment because the food stuff is accumulating over there. So that is how we get a picture of the Hirschsprung disease: a distal narrowed segment and a proximal dilated segment. Now here you can see that the passage of the intestinal content through the area is difficult. A compensatory dilation of the proximal area of the colon occurs. The clinical presentation is failure to pass meconium within 48 hours after birth. Like if the child has not passed meconium within 48 hours after birth, there is Hirschsprung disease. Intestinal obstruction such as bilious, vomiting and abdominal distension. The bowel is filled with stool, but it remains empty, but the rectum is empty. The rectal vault will be empty when you do the digital rectal examination. So the rectal vault will be empty, there will be nothing in that, and the bowel will be filled with stool as depicted by the chest x-ray. Like when you do the chest x-ray, the bowel will be filled with stool, or maybe the abdominal distension will be telling you that the bowel is filled with stool, but the rectum will be empty, and there will be a squat sign. When you do the digital rectal examination, you put the finger inside the rectum, and that maneuver dilates the rectum for a while, and then when that is dilated, so the stool that is accumulating proximal to that will be pushed into the dilated segment, and there will be a squat sign, and that is seen with the Hirschsprung disease. The tone of the anal sphincter is usually increased. The rectal biopsy, the rectal suction biopsy, because if we do the rectal biopsy alone, the rectal biopsy will pick segment from maybe mucosa only, but we want to take a submucosal segment, so we do the rectal suction biopsy. Will take a deeper, give a deeper specimen, and then we examine that, and then we make a diagnosis of Hirschsprung disease. So rectal suction biopsy reveal an aganglionic segment of the bowel. Here you can see the normal sigmoid colon and rectum, and in this case, this is the problematic area in which there is narrowing. Affected area by the Hirschsprung disease is narrowed, and the proximal area is becoming dilated, and this is Hirschsprung disease. Now we'll start with the GIT anatomy in the next session. Until then, Allah Hafiz, fi amanillah, and take care.